I would like to next introduce Dr. Yanni van Lokum from the Netherlands. And hello, Yanni.
Hi, Derek.
He is ready to go there, and you can see that he has marked out the left side of the patient and is going to do some volumizing. So let's get started.
Yes, thank you, Derek, for your nice introduction. So here we have Valerie, and Valerie is a 43-year-old French lady, and she has never had any cosmetic treatments in the past. She's completely healthy, she's not pregnant, she doesn't use any medication except for her hypothyroidism, and she has no allergies. So I was talking to her, and she said that she feels that she has some lines here in her face that she would like to have improved. And this is basically the general story that we hear in our practice. People see, as Dr. Rhoda told us just now, people see these lines and they want them treated. But when you educate them, if you educate your patient, they will understand that the reason that these lines are here is because there has been a mobility of the tissues in a downward and medial direction. So our job is to correct that by lifting the tissue back up. So if we look at her face, we can see one of the things that I see in her face is actually it's striking that she has some laxity of the skin. She's 43, but she has a very thin skin. And I think she could benefit from some extra collagen because she has lost some collagen over time. And especially after menopause, we lose 6% per year. We have a 6% per year reduction of collagen production in the skin. So she would benefit a lot from radias in the deep dermis to promote the neocollagenesis, and so that will give her a more strong skin that will make her look more young. So what we do with the vectoring technique is we try to lift the soft tissues below that. And if you come back to to what I said about inducing collagen synthesis in the skin, if you have a strong skin, it is more able to contain the soft tissues that lie below. Because the soft tissues are subject to gravity, they want to fall down, but if you contain them with a strong skin, they will be less likely to have more apoptosis. And then, besides enhancing the strength of the skin, we will have to lift the facial fat compartments that Dr. Tatiana has been talking about in her presentation. So I always start with the alar tracheal line. So we start at the ala and we draw a line to the tragus. So the line goes from here along the cheekbone to the tragus. Now, this is my reference line. I will use this line as my guide because as I'm treating my patients, I will, walk around them, I'll be behind them, I'll be besides them, I'll be in front of them, and it will show me the way as to where I am during the treatment. Now, I also want to show you some other anatomical structures. This is the infraorbital rim. I've already drawn it on the other side of the face, and this is a nasolabial fold, which you don't really see on Valerie. And parallel to the nasolabial fold, I draw a line from the tear trough down over the face, and we will get to the no injection zone. Okay, we don't inject here because here, first of all, there's a infraorbital foramen, which you can palpate with your finger, and you feel a depression here. And if you use a pen or another sharp, sharp object with a less blunt tip than this, you can really see that the patient flinches, and then you're at the right place. So this is a no-go zone. If you use needles, then you have to be very careful in this place because the facial artery comes along here. The angular artery is here. We don't want to compress that. Then I have marked the zygomatic arch, and I mark the inferior and the superior side of the zygomatic arch, and in between that will be my anchor point. Now, there has been a very interesting publication of Dr. Bessins. He's a French plastic surgeon, lives in Nice, and he did this publication about the reversal and replacement effect. And he noticed that if you look at an aging face, you can see different zones. You can see a fixed zone, which is not very mobile, and another fixed zone here, because the nose is fixed, the corners of the mouth are relatively fixed, and you have a mobile zone, and the mobile zone is between the two fixed zones. This is the zone in the face that has the most mobility. So actually, this is always our target area, to pull up and reposition the soft tissues at the anatomical location from where they came from. The fixed zones, they don't move so much. However, as Dr. Tatiana explained to us, we do have changes. We have bone resorption here, and we have bone resorption here. So they do change, but they are not mobile. So for lifting, we want to come back to the V-shaped face, and we can use our anchor point to actually lift the face. So if I take this anchor point and I pull, I can see that she would benefit the most from actually this direction. So this is my vector. You have to really look at your patient and feel where your direction is. And I feel that she would benefit most if I point my target towards this side. So from here, I want to pull towards here. And I will use a fanning technique using cannulas. You can also use needles, but because I feel that there's less hematomas with cannulas, I prefer them. But of course, if you feel more comfortable, you can use needles as well. With a cannula, I will make fans, and with every fan, I can make little steps of lifting. Okay, so we'll start off. We're going to do some more stuff, but I would like to start off with this right now. So we do one thing at a time. Okay, thank you. So to begin with, it is not very necessary, but I like to give my patients, as least discomfort as possible. I would like to start off with giving her a little bit of local anesthetic onto the tip of the zygoma. And this local anesthetic is with adrenaline, and actually this adrenaline is the key, because even though we're going to use a cannula, we have to use a normal needle to puncture the skin.
Yanni, a couple of questions. What gauge needle is that you're using right now?
This is a 27 gauge needle, and I will be using a 27 gauge cannula for the actual injection.
And are you using the cannula that we have all seen at the Merz booth?
Yes, I'm using that cannula. Yes.
Great. As I understand, that cannula will be available in both Europe and the United States within the next couple of months, and I'm looking forward to using it myself. You have quite a bit of experience with it.
I've been using it for quite a while, indeed, yes.
Right. And I'd like to remind the audience as well is that as we're going through these injection sessions, we will have a Q&A session to follow, so please, everyone, write your questions on the cards, raise your hand high, and the hostess will pick them up.
Great. Well, just to show you, because I'm using the same gauge needle as a cannula, it is important that you're not going to be struggling too much to insert your cannula. It's kind of clumsy if you're struggling to get your cannula in. So what I do is when I retract my needle, I kind of scrape my way back so that I have a little bit better of an opening. And so the cannula has already been primed. That's my lovely assistant, Josine, who did that for me. But of course, you have to make sure that there is no air in the cannula. And what I do is I put some pressure on the plunger and find a nice victim to to aim at and tip off the little bit of radius that's at the tip. Okay, so now we'll begin, and we can clearly see where my injection site is because there's a little bit of blood coming out. And so we have to inject insert the needle. Hey, I do feel a little bit of struggling here. Okay, so that's no problem, because what you could do is you can use kind of a pencil rolling way, and you kind of drill your way into the skin until you're inside.
It does take a while before you can get adept, and you know, if you have a patient that's had a facelift or something, it's very hard actually to get it through.
Mm-hmm. Because of all the fibrosis, yes. And this is a very nice trick that I've learned is to really roll your syringe. If you do that and at the same time advance it, it's much easier to get to the fibrous tissue. So I will take the skin, I will lift it up a little bit and try and advance my needle through the soft tissue until I get to the periosteum. And when you get to the periosteum, you feel it sliding. Now, if you look at the direction of my cannula, you can notice that it is in the same direction as my alar tragal line, the line that I was talking about that is going to be your guide during the procedure. So I'm advancing the needle over the bone. Am I on the bone? Yes, I'm on the bone. I can feel it. And advancing the needle. This might be painful for some patients because the periosteum can be quite sensitive. You can see it's quite high up. So I'm a little bit too high. I go back and I have to find another way. You see, with the cannula, it can be much more of a challenge to get to the right position that you want, because the cannula will take the path of the least resistance. Now, when I just came back, I did a retrograde deposition of Radiesse, and I injected 0.1 milliliters of Radiesse. I'm going back, and I'm following the periosteum, and I'm right here with my tip of my cannula. And I talked about the Besant's study about the mobile zones and the fixed zones in the face, and what he has actually shown us in that study is that this area underneath the eye, actually the orbicularis muscle where it inserts into the skin, is a very, very important target area for repositioning. Now, I'm making different strands in a fanning technique. I have to go back down to the periosteum, and there we go. So I'm underneath the fat compartments, and I want to be underneath the fat compartments if I want to lift them. Also, you might notice that when I'm far away from my injection site, from my entry point, I put more pressure on my plunger, and as soon as I come back to the entrance site, then I put less pressure on my plunger.
Yanni, how much are you depositing with each pass, with each linear retrograde pass that you're doing?
Actually, that would be approximately 0.1 or 0.15, sometimes 0.2. It actually depends on the patient. With her, she doesn't need so much because she already looks really good, and I don't want to change her dramatically, and she doesn't want that either. She wants a nice and natural look, so she just wants me to enhance her beauty.
Do you ever put it in the subcutis?
I do put it in the subcutis, but a very important thing is not to put it in the fat compartments, especially around the jowl area, because if you inject Radiesse into the fat compartments and not above the fat compartments, then it will make the fat compartments itself heavier, and they will have more of a tendency to go down. So if you want to inject in the fat compartments, it should be in the fat compartments that have lost volume over time, like the deep medial fat compartment. You can inject there. You can inject in the deep medial fat compartment. Okay, you see that I'm continuing my fanning, and I'm actually putting in a lot of different strands of Radiesse, and they have been very deep on this side. Something I forgot to tell you about this alar tragal line, because above that line, I inject on the periosteum, and below that line, I inject subdermally or intradermally. This is actually a rule of thumb because there's a few exceptions.
Yanni, that's a really excellent comment, because I do exactly the same thing that you're doing. And
Nice.
you've already made the point, but I'm going to make it again. You
Yeah.
put a point over your no injection zone at the exit of the infraorbital nerve. There have been reports of prolonged anesthesia with both HA fillers and calcium hydroxylapetate when you're injecting on the epiperiosteal plane in and around that infraorbital nerve. So I think it is a very wise idea to do exactly as Yanni says there. Do not be injecting epiperiostally in that area. I, however, do inject in the immediate subcutis in that area because a lot of people will have a volume deficiency there.
Yes. Well, the deep medial fat compartment is a target area for injection. However, because of the proximity of the infraorbital foramen, you should definitely be careful in the deep plane there, definitely. Okay, so if I go back and have a look, you can already start to see a little bit of swelling. And this is actually an important thing that you have to discuss with your patient beforehand, because radius can give more swelling than most hyaluronic acids. It has some advantages over hyaluronic acid, but it also has a little disadvantage, and that is that it could create some swelling. This is temporary, of course, and if you don't tell your patient and she swells up, especially if you inject over the periosteum here, they might have extra edema.
Many of the patients, though, love that swelling. And then
They
you have to
do,
warn them
they
that the
do.
swelling is
It
going
will
to go
away.
down.
Yeah. All right.
You know, one little pearl with Radiesse is that I often, as soon as I have finished one side of the face, I hand the patient a mirror because the swelling, the edema has not yet set in. And then you get that wow effect, and that's what they often say. They say, wow, that looks great. And I tell them, if it begins to swell and you look more swollen than you do now, don't worry, it's going to go back down to this level. And I find that very useful.
Exactly. Okay, so
I
here...
have to say, unfortunately, the swelling is going to go down.
For some patients, yes.
Okay, so done the stab incision. You want to find your entry point, and you can do that by pinching the skin a little bit. And then to insert the cannula, make a pencil rolling move. And you see that I'm struggling because she has quite a strong skin in this part. And you know, if a patient is used to needles, then it might feel a bit rough for her, but she didn't have any previous injections, so she thinks this is quite normal. Okay, so I'm down back to the periosteum, and I'm advancing my cannula over the zygoma and towards the tear trough area. And as you can see, I'm very careful here because this is, of course, a very delicate area, and I'm injecting a little bit of product, and I will give her a little massage after that. So I'm not going to the foramen, I'm staying away from the foramen.
And you're still epiperiosteally, yes?
Yes, I am. Okay. Give her a nice cheek. Staying away from the no injection zone. And then I move to a more superficial plane because I'm getting below the alotracheal line, and this is to enhance the collagen synthesis in the deep layers of the dermis. Okay, so normally I would put down the chair now because I'm upside down, and but I think it's better for the camera if I keep it like this. And you can see that I'm advancing the cannula. It might seem a little bit rough if you're used to needles, and you can feel the fibers of the skin scraping against the tip of the cannula. And sometimes you have a harder part, and then again you can use the pencil rolling technique to actually get through the fibrous parts.
It appears that you're in the immediate subcutis here, correct?
Yeah, I'm actually scraping against the dermis. I can't really with my cannula get into the actual dermis because of, you know, it's a blunt tip. So the path of the least resistance is the sub-Q, obviously, but I try to be as superficially as possible to create the thickness of the skin, the collagen, new collagenesis in the deep dermis.
Patients often do mind this more than the needle, but when you tell them that they won't bruise, they're very happy to do it.
They love that, yes, because even though I don't know about how it is in the U.S., Rhoda, but are people very open about their treatments in the U.S.?
You mean, do they tell other people?
Yes, or do they prefer to have it a secret?
Well, they will usually tell other people about fillers or toxin, but they don't ever tell anybody about liposuction.
I see, I see.
As a matter of fact, 1/3 of our patients don't tell their significant other, and I can't understand that, but that's how it is.
Okay.
But I think people want to look natural, and most people would like never to say they did anything.
Yeah, exactly. Well,
And
they
this
tell their
gives
best
a-
friends usually.
Yeah. Yes,
And they
but
do
they
tell
don't tell other people.
No.
And how much product have you applied so far?
This is
Yanni?
one syringe so far, yes.
Very nice result there. You can really see the triangular shape returning.
Yeah. Can you hold your face like this? Can you see any difference so far?
Yes.
If you look at her face? Okay,
Yeah.
that's nice.
Definitely.
Okay, she would definitely benefit from having another fan here, but I think we're a bit short on time because people are starting to move a little bit nervously here. No? I'm okay? Okay, so we can just continue the treatment like we're doing. Can I have some light? Okay, yes, thank you.
She looks very good.
Okay, so we've done our augmentation starting from here. And so from here, I would like to give her another fan to treat this area because she needs some neocollagenesis here. She would definitely have benefit from that. Let's see.
So Yanni, I do a lot of mid-facial volumizing, and I love my needles. Why should
Me
I
too.
switch? Why should I switch to a cannula?
Oh, you don't have to switch to cannulas. You can keep on using needles. However, with a cannula, you know, do you want happy patients?
No, he doesn't.
You know, for me,
I live in LA where a bruise is a cause for a fundraiser, so yes, I want to produce as little trauma as possible.
I was in Dubai recently, and people that have had nose jobs, they keep their little nose protector on way too long because they want to show other people that they've had a nose job. And but where I'm from, it's they don't really want to show
Right.
that they have been treated. They would like to stay. They would like to have the smallest downtime as possible. So the downtime with cannulas is shorter. You have more swelling with cannulas, but you have less hematomas. The hematomas can last for a week, sometimes 2, and the swelling will last for a few days.
You know, one of the easiest areas to use the cannula because it's the least fibrous is the mid-face. So sometimes I will use that in the mid-face because that's where the ecchymosis tends to stay the longest and be the most visible, and then use needles elsewhere if the patient is fibrous and it bothers them to have the cannula. They can hear the cannula sometimes go through the
Yes.
skin.
Okay, now I think I've bent the cannula, and I would like to have a new one, if that's possible. Thank you very much. So, as you might have seen, to get the most control over the depth of your cannula, it's very helpful to stretch the skin, because a stretched skin is easier because you will have all the layers in line. And then you can advance the needle easier and do your retrograde threading. And there we go again. Are there any questions from the audience in the meantime?
I think we're going to have a question and answer session here as soon as we.
I see. All right.
Okay, but there are a few cards that I have here, Yanni. So why don't we entertain a couple of questions while we continue on? Here is an excellent question, specifically for you. Why should I attend a Radius injection training session before using Radius?
Well, you know, it depends on how experienced an injector you are, of course. Training is always nice, and if you look at another doctor who does a treatment, you can always pick out something that you like. I mean, if I love to see colleagues work, and I always see something, you know, that I might use in my own practice. So it's always a good idea to follow training. But Merz, if you're using Radiesse and you haven't done it before and you're used to hyaluronic acids, then it's a good idea to get some training, because there are some considerations about using Radiesse. We, for example, have no hyaluronidase with which you can dissolve it. So you should know that it's better to undercorrect than to overcorrect. And even though there have been no granulomas in patients that have been treated with Radiesse alone, there have been nodule formations, and especially in the lip area, and that's why we shouldn't inject Radiesse in the lips. So, you know, these are all things you can learn from a Radiesse training, and in the meantime, I'm treating her mid-face area here in the deep zone. I'm on my way back to the deep zone here in the tear trough area, because I feel she might benefit from a little bit more volume here.
Yeah. Now, Yanni, you're in the subcutis there, right?
Yes.
Okay, great. And, you know, along the lines of this question about a Radiesse training session, I think it's quite important to get as much training as possible, because you want to learn what not to do. And Yanni started off showing us where not to inject on the epiperiosteal plane around that infraorbital nerve. There are other danger zones as well, particularly the angular artery, which runs just right lateral to the nose there.
Yes.
You want to be very careful when you're injecting the nasolabial folds. And I think that the cannula would probably offer a safer way to treat that area, because it's not going to easily get into the vessels and create an occlusion.
Definitely, definitely. And to come back to that question about the training, Merz has a very good training program. They have all these field clinical specialists that are actually, their job is to train doctors. So they have all these training programs, and they're actually very knowledgeable. When I first had a training, I was a little bit, how would you call that, humble, because this girl, Josine, who's not a doctor, knows so much about anatomy, and at that time, maybe even more than I did myself. So it's very, very, very good to get some training from Merz with Radiesse.
Yanni, another question, since you are doing a lot of injections upon the supraperiosteal or epiperiosteal plane, there's a lot of talk that Radiesse is a natural substance that is found in bones. Mm-hmm. So the question here specifically for you is, can Radiesse form bone and soft tissue?
No, it cannot. That has been proven in different studies. It does contain the same substance that's also occurring in bone mineral, but it needs the osteoblasts to really create bone. And there's no osteoblasts in soft tissue.
You're getting a fantastic result there, by the way. She looks really wonderful.
Thank you. And you know what I was looking at? I was just looking at her face, and I thought to myself, maybe she needs a little bit more hair, you know, to kind of lift the lateral side of her eyebrow. I really like that look. So I'm going to go back and, if you don't mind, and use the same injection site that I've used previously. It's probably blocked now because of the coagulation. And I will go back with my cannula, and just quickly, before we have to close this session, go towards the eyebrow. And you can see that she has a nice skin laxity, and that's why I can use that skin laxity to actually get to where I want my cannula to be. See, I always palpate and look at where my cannula is.
And what plate are you on right now?
I'm just in a sub-Q.
So you can always use the rest of that syringe somewhere.
Oh, yes. There's all these different syringes, and the only time I use a 0.8 ml syringe is when I do noses. because there's hardly anything needed in the nose area. But for the rest, I always use a 1.5 syringe, and I can't wait for the 3 ml syringe to come out, because you can always continue and find another place to work at. Okay, just to finish off the session, I would like to demonstrate also a technique using a needle, and I use the 28 gauge needle. It has a 27 gauge lumen, and Merz can also supply you with this if you buy radius from them, obviously. So can I have a swap, please? Thank you. And you remember that I told you that this is the alar line above this on the periosteum, below this in the dermis or the sub-Q. There's a few exceptions. That's the place just below the ala for the nasolabial fold. It is the pregel sulcus, where you can inject on the bone, and it's the mentum, where you can also inject on the bone. It's very safe. So I will inject her here in the top of her nasolabial fold. I have to find a victim again. And I inject my needle perpendicular to the skin and go all the way down till I touch the bone. I can feel the tip of my syringe touching the bone. Can you see it on camera? Is it okay like this? Perfect. So I inject about, she doesn't need much. She needs about 0.1 or 0.2. And that will actually lift up the top of the orbicularis muscle. So I'm below the muscle, and I'm also away from the alar artery that we do not want to compress here. She doesn't need anything more, I think, in the nasolabial fold. She's fine like this.
Yanni, I think you've done a beautiful job there. It's just about time
Thank
for
you.
us to move on to the conclusion, and then after that we will move into the question and answer session.
Okay, great.
Give a big round of applause.
Thank you.
Why don't we go ahead and put the pre and post of your patient up
Let's do that.
on the screen so we can see. That's
Yeah.
a very, very nice result. And here we have one side treated, one side untreated, correct?
Yeah. I actually wanted the pencil removed, but that's okay. You can see the difference much better now if you compare it to the whole painted face that I just had with all the white pencil. You can see a nice lift of the mobile zone in the face. And to come back to the Ballanzino study, this is the zone of the face between the two fixed zones that is most important as a target area for injection. So she looks natural.
And happy.
She looks very happy.